concern. And as I mentioned that, we all know that VEGF plays a very important role in ROP. And it was way back in 2005 when Dr. Hugo first used Avastin in ROP cases. And then we all know about this, again, highly controversial paper in New England Journal of Medicine, the BEAT ROP study, which actually compared head-to-head the use of Avastin as primary therapy versus laser. And what it actually showed that the Avastin or the anti-VEGF worked very well with the posterior disease, the zone 1 disease, and it did a little better also than laser as far as the posterior zone 2 disease is concerned. We actually first presented our series in the Academy in 2008. However, there are a lot of questions which still remain unanswered. And we'll go through this one by one. The indications, the dose, the timing, which drug to use, and most importantly, how to follow up these babies in whom we have used Avastin or Lucentis. And we still know the long-term results as well as the adverse events locally as well as systemically. I think the most important question to start is when to give. And if you read the BEAT ROP paper, Dr. Helen has very nicely pictorially described the whole pathogenesis of the ROP disease, which is divided into the phase 1 and the phase 2. The phase 1 is where there is increased oxygen and decreased VEGF, and in the phase 2 where there is decreased oxygen and increased VEGF. And it is the beginning of this phase where you should, if ever, use anti-VEGFs, not before that. So essentially, anti-VEGF should never be used before 32 weeks because then you will essentially prevent the normal vascular genesis which is required for those babies. If you use it too late, you would have had the fibrous tissue set in, which would again cause the complications which we are all afraid of, causing fractional detachment, retinal breaks, vitreous hemorrhage, so on and so forth. So as of today, there are certain indications where you could use the anti-VEGF either as primary or as rescue therapy, as Dr. Dogra said. And this would include the type 1 ROP, the Rush disease, babies who have severe persistent tunica vasculosa, the pupil doesn't dilate. So maybe you can prepare the baby by giving anti-VEGF, and then once it resolves, you go and add your lasers. Severe ROP again, the zone 1 or the posterior zone 2. You can use it for cases who have persistent ROP or have recurrences after laser, and very rarely in a very sick baby who cannot tolerate the laser because of the timing, so on and so forth. Then just to buy time, you can use this method of treating this laser. I'm going to show a short video of how I give my injections, and I usually do it under topical anesthesia. This is a small edited video. I do it under topical anesthesia under microscope. In the very early stages, and still now, in most cases, I like to do an anti-HM paracentesis prior to the injection with a 30 gauge needle, and then about 1.5 millimeter from the limbus. I usually inject half the adult dose, and under the microscope, it gives you a good control. You can see the drug actually through the pupil. I always dilate the pupil on the day of the injection, and this entire procedure hardly takes about 10 seconds. So you don't need any anesthesia when it comes to giving these injections. Sometimes you can, in a very sick baby, you can give these injections like you do the laser even in the NICU. And in this case, you have to do it in a naked eye. You can use magnifiers or loupes, but this is just one photograph where I had to do the injection in a very, very sick child, very aggressive case. Coming to the question, the million-dollar question, which one to use, and the debate never stops, whether you use Lucentis or Avastin. However, we know that Macugen is not effective, and Dr. Tracy did a good series and showed that it was not effective. And for various reasons why we use Avastin, because it is cheap, and initially it was thought it is a larger molecule and could have lesser systemic absorption, but I'll show you it is not so. Now, just to show you a few cases where you could usually use it as a preparation, this is a severe tunica vasculosa lentis, severe posterior Rush disease, non-dilating pupil. So you can see this is even just the third day post-Avastin, how nicely the pupil starts dilating, and then you can add your lasers. This is again the severe type 1 disease, and you can see this, that after the injection it responds very nicely, and in many cases you can see the vasculature progressing even up to the vein periphery. Again, you can see the severe disease. This is a severe avascularity, and with this one injection, again, there is complete resolution of disease and progression of the vasculature up to the periphery. Now, this is a very borderline disease going almost into stage 4A, and you have to be extremely careful in using any anti-VEGFs in these cases. And as I'll show you, we have first reported these findings that in many of these cases, we see a localized vitreous whip, like a localized PVD occurring, and you can see the vasculature actually progressing beyond, and the vitreous separates locally. And we don't know the repercussions of this, but we do need a long-term follow-up, because this might cause retinal detachment in the future. These are just a few cases of severe cases where we combine Lucentis with laser, and a case of Lucentis monotherapy. Now, a very nice paper presented by Sato et al., which actually showed that after intravitreal Avastin, you have a very high level of serum Avastin and a very suppressed serum VEGF level even up to 2 to 4 weeks. What is the dose required? Well, everybody does it differently. Majority of the people use half the adult dose, but sometimes we even use 1/4 up to 1/4 the adult dose. Again, when you use Lucentis, some people use full adult dose and some like to do half the adult dose. Now, coming to the important question of complications, and we see a list of complications that have been reported in the literature, which includes the local complications of hemorrhage, infection. I think the most important complication, so to say, in people who use only anti-VEGFs without laser is the persistent avascular retina, and there's a big issue which needs to be addressed. You also have development of traction retinal detachments, macular holes, breaks, and of course the problems of recurrence cases like Dr. Dogra showed. Subhadra has also reported 3 or 4 publications in various complications, which include choroidal ischemia, ruptures, vascular attenuation, perivascular exudation, and optic atrophy. We've tried to look at some of the aspects regarding the safety issues, and what we've done in a large series is we've performed the ERG and VP in these eyes, all eyes at around 4 to 6 years follow-up, and even beyond. Now we have about 8 years follow-up in some cases, which showed pretty good normal values as compared to the normal age match. We have also done a detailed neurodevelopmental analysis by a pediatric neurologist, which shows majority of the eyes were within the normal limits. We are currently pursuing doing the OCT evaluations at long-term follow-up at about 7 years, and it shows none of the major structural changes occurring in the fovea. Now, refraction is a major issue, and people believe that if you use Avastin, it leads to lesser incidence of myopia, which is not a case that we have found in our series. And this is just to show you a few of those vitreous changes that I have shown you, which we have reported. Just a few complications, the avascularity, the fibrous membranes. So to conclude, we believe that the anti-VEGFs is more efficacious for the most posterior disease, the APROP disease. You could use this as primary therapy just to buy time, or you can use it as your rescue therapy. The safety is still unproven, and you need to be very careful and trained on how to do it and then how to follow up. You have to be aware of the complications, particularly the late complications like the late recurrences, the RDs. If you see these babies at 7 years, it almost looks like an FEVR-like picture if you're not lasered them. And of course the issues of the systemic toxicities for the lungs, kidney, heart and bones. So you have to weigh the risk-benefit ratio case by case, baby by baby, and maybe in future in certain regions where the laser is still not available, it could prove as a time-buying tool till you can transport the baby for your laser therapy. Just 10 seconds. I just want to thank Dr. Anand because he's been instrumental for us. We've started this telemedicine project in Gujarat and we're doing it in 4 districts currently now. He's trained our team and we have this van and the RedCam shuttle, and I'm very happy to say that in just 18 months we've screened over 2,000 babies with 4,000 screenings and have treated 200 eyes so far and have prevented blindness, and we're using his telemedicine model as well. Thank you very much.